I see the numbers are populating, and we're just so happy that people are coming from the four winds around this great cause of improving stroke outcomes and improving the prevention of stroke. So what a magnificent era we're in to have the innovations that will be presented today. I think many of you know that this is a topic very near and dear to my heart, as I lost my own mother to stroke when I was 15 years old. Now we're 313 Right Care Initiative virtual University of Best Practices sessions later, and people are starting to gather from greater distances. We first started by creating regional communities in 4 major metropolitan areas of California: San Diego, Sacramento, Los Angeles, and our latest one was a challenge by the former undersea medical officer to the Navy SEALs, Dr. Scott Flynn. Scott, can you come on and wave? I see you just have your picture up, but if you can't, I totally understand. Dr. Flynn is quite the multitasker. So I want to say thank you to Blue Shield of California for helping us to start the Silicon Valley chapter. And thank you to our mothership, UC Berkeley School of Public Health, to the California Department of Public Health, our many supporters across the world of academia, and the California chapter of the American College of Cardiology. And of course, Chuck Toeniskoetter has been a major supporter of our work, and thank you so much for that, Chuck, if you can wave. And thank you to our biopharmaceutical partners as well. Next slide, please. Most of you know me, some of you don't. I started this work really as an undergrad at UC Davis. I was pre-med, and I found myself more interested in clinical quality improvement even back as an undergraduate. So I went and I studied health policy at the Kennedy School of Government at Harvard. And 30 years later, here we are on the ground working to improve care. Next slide, please. So I think this slide really grounds us in what is critically important, and that is we need to raise awareness that even starting in the early parenting years, in the 35 to 44 decade, according to the U.S. Centers for Disease Control data, we already see that more women are dying from cardiovascular conditions than from the things that they're regularly screened for: breast cancer, cervical cancer, and the same with men. Only it's much worse for men. So we need to start deploying this early screening that is available to find subclinical atherosclerosis and not wait until people have the events like dear Ram Madduluri and Chuck Toeniskoetter went through. So we need to rally around changing people's notions of what kills them at early ages. Next slide, please. So we have been working on the same metrics for more than a dozen years across many universities, public-private partnership. We focus on the control of LDL, blood pressure, and blood sugar. And we do that through running these forums where we come together to learn from the wonderful presenters we're going to learn from today, and to foster co-opetition among the competing health systems. I am so grateful to my co-founder, the former chief lawyer for the state of California for Health, Reverend Warren Barnes, who was also a minister. He assured everyone that by gathering to solve quality improvement problems, it was not a legal issue. And he created our motto, which is that we compete against disease and not each other. Next slide, please. We really ground ourselves in data. We want the health systems to know whether or not they are achieving good control for these major metrics that do drive events. These are often symptomless buildups to these horrible events. Welcome to Dr. Nirali Vora from Stanford. I see that you've joined us. Next slide, please. This is our synthesis of promising best practices, and it is what we teach in pretty much every session in a different way. And for any health system that wants to learn more, I'm happy to do a one-on-one session with them. Next slide, please. And here we have our wonderful co-chair of our technical expert group, neurologist Nirali Vora from Stanford. Nirali is has been a leader in the Right Care Initiative now for going on 5 years. It's pretty amazing, and I'm so grateful for that. I think I will just allow you to introduce yourself and the next portion of the program, and thank you for pivoting away from your patients to lead the meeting, Nirali.
Yeah, thank you guys, and welcome everyone. Super excited to be here. And yes, I was just finishing up my last clinic patient where everything that we talk about here in the Right Care Initiative is so critical and so important, and I use it every day. So maybe we'll go to the next slide, and we'll introduce, actually, do we have the video, or did you guys already do? Okay, maybe we can go to the next slide if it's there. But, you know, part of what we're going to talk about is how to reduce the time it takes for patients to enter the stroke system. And Dr. Spokoyny, who I'll introduce shortly, is going to talk a lot about that and what innovations she's worked on to reduce the time it takes for a patient when they know they have stroke symptoms to get into the systems that we know work really well to cure and stop strokes. But the other major issue is, how do we get our patients to know that they're having strokes? And unlike a heart attack, where we might be able to list 2 or 3 symptoms, strokes are super heterogeneous. Depending on where in the brain is affected, it could be any number of symptoms. And for years, we've tried different public health messaging. The American Heart Association tried the FAST mnemonic, and we built on that, the Be Fast mnemonic. Earlier this year, you heard me talk about the Salsa Against Stroke, or the Be Fast Dance Challenge, to raise awareness about what Be Fast symptoms are. And so going forward, it's also thinking about prevention and linking prevention, and not just at the time of having the stroke, but how do we prevent and know the things that we need to know in order to prevent stroke, like knowing our numbers, knowing our lipids, knowing our A1C, or knowing our blood pressure. And how do we message that in a way that fits with those that are most at risk? And also recognizing that protecting against stroke also protects memory and also protects brain health. And so I think someone from the Right Care Initiative could play this video, which really gets at how we can get better public health messaging for those most at risk with stroke and brain health protection. So I think we're going to play that now, and hopefully people can give a thumbs up if the sound is working. Okay, so very short, very brief, but really kind of upping the game on better public health messaging, linking memory, linking stroke, and knowing your numbers to start to get people aware about stroke. And then we can move into teaching them about recognizing stroke, some signs and symptoms, and then getting them in the door faster for treatment. So keep those ideas coming. I'm sure we're going to see a lot more of that. And now we'll go to the next slide, and I get to have my privilege to introduce my former stroke fellow, Dr. Ilana Spokoyny. So Dr. Spokoyny has had an illustrious career as a neurologist, starting out with her residency at UC San Diego and excelling in her stroke fellowship here at Stanford. From here, she worked on a lot of great systems-based initiatives. She's all about thinking about quality improvement operations in the system. And was recruited to be the director of the mobile stroke unit at our nearby affiliate hospital, Mills Peninsula, which is connected with the CPMC system. And I've seen, Ilana, you've been working on research, really helping to direct the BEST MSU trial, which I suspect you'll be talking about a little bit today, and exciting us about really exciting all of us about this innovation with mobile stroke units that are probably going to become more of a reality in our area. So I will hand it over to Dr. Spokoyny. So great to see you.
Great to see you too. Thank you, Nirali. And let me share my screen and we'll just jump right in.
All right, looks good.
You can see, everyone sees the single slide. Wonderful. Okay, great. So like Dr. Vora mentioned, I'm going to be talking today about mobile stroke units. And one of the taglines, I have many taglines, I always debate which one to put in the front of the presentation, but we bring the hospital to the patient. And this can be, you know, a game changer in the world of stroke. I think that it is. And it involves a lot of perspective shifts. It involves a lot of thinking about the way we treat our stroke patients and turning that on its head a little bit, going back to how can we improve the process by actually stretching out the amount of time we have to work with, though we are always racing against the clock. And then Dr. Vora hit the nail on the head, which is that we still rely on patients to recognize their stroke symptoms and call 911. And so public health initiatives that focus on the recognition of symptoms and bringing them into the system are all prerequisites for programs like this to be successful. I'll tell you a little bit about what we've been working on. So first of all, not that you all need this, but just as a reminder, how big a deal is stroke? Well, it's a very big deal. So every year we get this update from the American Heart Association about heart disease and stroke statistics. And what's new this year? Well, the numbers look from 2018, the calculations, you know, essentially about the same, but maybe even slightly more of a health, you know, a public health problem, is that someone has a stroke every 40 seconds in the United States, and somebody dies from a stroke every 3 minutes and 30 seconds. There are 800,000 strokes per year. About a quarter of those are recurrent strokes. So people who have had a stroke before, unfortunately, having a recurrence of that disease. And then each day, you know, more than 400 people die from a stroke. More so than death, we have to think about the impact of stroke disability. So it's the #1 cause of adult disability, with actually up to 2 to 3% of people affected by stroke. And you know, this comes into play when we look at the United States and we look at our maps from the CDC. It's not equally distributed, and that's something else to think about. You know, the prevalence is not the same all throughout, and that may be as a result of differences in access to care. We also look at stroke death, and we see that this is not an exact mirror of stroke prevalence, which also might indicate that there are some population disparities and care disparities among the different states. We know this. We can drill down a little bit even more and look at California. We look at by county. We see that there's also variation by county, not just by state. And so when we really think about stroke systems of care, it's impossible to say this is the best system for the United States or for the world. You really have to look at it on a very, very, you know, small and local level first before you move to the broader population. So we know that time is brain. We hear time is brain, but I'd also like to say it's time is also independence, and time is money. And so we know that about 2 million neurons are lost for each minute that a stroke goes untreated. And we also know that non-treating a stroke, every 30-minute delay will lead to a 15% lower likelihood that that person will have a good outcome following their stroke. So while we make strides and advances in technology to improve treatment windows and be able to treat stroke patients later in the process, we still know that better outcomes are tied to earlier treatment. And as we think about the significant cost that stroke puts on our healthcare system, we see these staggering numbers, over 100 billion annual costs, and 2/3 of that is attributed to indirect expenditure. So not the hospitalization itself, but other costs that are associated with this. Loss of ability to work, so earning potential, and especially for younger patients, this would have a much bigger impact for their remaining years. And then caregiving costs. We think about, how other people, family members, friends, other caregivers will be affected by this. And again, not only financially, though there is, of course, that component, but emotionally. So there's a big change when somebody has a stroke and has disability from stroke in their loss of independence and potentially in their feelings of being burdensome to family, whether or not that's valid. And that comes up a lot for us as stroke physicians. And so anything that we can do to reduce this burden, both the social, the emotional, and the financial burden of stroke, we want to do. So we think about acute stroke treatment, we can have some obstacles, and we're always looking for innovative ideas and technologies that can help us overcome these obstacles. So one obstacle is that before you can treat an ischemic stroke, you need a neuro exam and you need imaging. And another obstacle is that not all hospitals are created equal or built equally, so not all treatments are offered everywhere. And our goals in treating our stroke patients are to initiate treatment as soon as possible, as well as triaging to the appropriate level of hospital. We think about stroke hospital systems of care, primary stroke centers, which can administer thrombolysis, so medical management for ischemic stroke, thrombectomy capable stroke centers, which can perform that, the medical management as well as mechanical thrombectomies, and then comprehensive stroke centers, which can do all of the aforementioned, as well as specialty neurosurgical care for hemorrhage patients in particular. And so when we think about a stroke system of care, once again, back to thinking locally first, you have to see what is the layout of the county. Where are the hospitals located? What types of hospitals are they? Where can patients get the care that they need before you start to build a system of, triaging patients to one hospital or another? You have to know what you're working with. So in the paradigm of acute stroke treatment, and I mentioned this and Dr. Vora mentioned this, but the symptom recognition comes first. So understanding the stroke symptoms, being aware of them, and even having an inkling of, hey, this might be a stroke, I should call 911, and making that motivation and empowerment for the community, that's a big task for us as stroke physicians and as people who care for patients with strokes. Following the 911 call, we have in-field triage, then the patient is transported to the emergency department, following which there's an evaluation by the stroke team, imaging studies, and ultimately a treatment plan is developed. So which systems of care improvements do we already have? Well, we've focused in hospital on the alert. So there's a ring down to the emergency department for incoming stroke codes from ambulances. Multiple providers are notified at the same time of an incoming stroke in the emergency department. Once they're in the ED, they can go straight to CT, so straight to imaging, just quickly stopping in the emergency department to make sure that they're stable. We can proceed without lab results unless there's something specifically that we must get before treating. Same for chest X-ray. We can pre-mix some of our medications that we use, the clot-busting medications, TPA or TNK. A lot of places, a lot of hospitals have moved to using tenecteplase because of the ease of administration, because the idea that this will, again, speed up the treatment for these patients and not delaying for written consent now that these medications have been accepted as standard of care. Now, all of those are excellent. I've worked on many of those at different hospitals throughout my training and in my early career. And at the same time, while we're very proud of that and we continue to try to iterate and improve, we're really still starting our intervention the moment the patient hits the door. And our goal is to be able to treat them faster. And so with that, we propose a shift from series to parallel. So back to a little bit of electrical engineering, which maybe you didn't think my talk would include. But this will allow us to save time and deliver more efficient care. So instead of one thing after another, can we do some things at the same time? Can we do parallel processes to help our patients get their treatment faster? So the symptom recognition and the 911 call, that is still something that the time for another talk, an entire lecture, maybe a series of lectures on what we can do from a public health perspective to improve that. But once we're at the step of in-field triage, can the stroke team evaluation occur at the time of in-field triage? While we're transporting to the ED, can we have completed our imaging studies and develop a treatment plan all at that same time? So when we look at this paradigm shift into the pre-hospital space, using that extra time, that time that we didn't have before. So there already is pre-notification, like I mentioned. There's new technology that has come out to allow first responders to communicate with the emergency department and with the physicians in the hospital. But really, it's a lot of untapped potential. So we can rely on first responders for much more than just transport. We can activate these parallel processes in the hospital at the time of the 911 call. And once we have more information, can we actually determine the appropriate destination, alert the appropriate teams all in advance? And, stroke didn't, which I think is, awesome and the best field ever, and that's what I do, we didn't invent this. So we've been thinking about triage in trauma and in cardiology for a while. And so taking models from our colleagues there has really helped us think creatively about what we can do for our stroke patients. And we move the needle back to the time of the 911 call. So if we're thinking about something that can help us make this paradigm shift, something novel and innovative that would leverage pre-hospital systems of care and employ parallel processes, sounds great. That's the mobile stroke unit. And that's what I'm going to talk about today and tell you a little bit about our specific program, as well as some of the research behind it nationwide, as well as internationally. So what is a mobile stroke unit? Well, it's a fully operational 911 ambulance, has an EMT on board, a paramedic. It also has some additional features that make it very special. So there's a CT scanner on board. There's a serotonin scanner. You can see it in the image there. There's a CT technologist on board to help operate the scanner, as well as a critical care stroke nurse, a stroke neurologist, either via telemedicine or in person. We have the capability to perform labs, coagulopathy labs, or coag panel and chem panel. And we also have medications that wouldn't typically be available on a regular ambulance. And those include IV thrombolytics, anticoagulant reversal agents. So for people on blood thinners who end up having a hemorrhage, we can give them something in the ambulance, in our ambulance, to reverse that medication. We also can treat blood pressure immediately at the scene with IV medications and drips as well. So our San Mateo County Mobile Stroke Unit is very much a team effort. And so I find myself occasionally saying I, and really I should be saying we every time, because this is something that would not be possible if it weren't for really a strong collaboration and teamwork from all of the parties listed here. Philanthropic donations is how this unit came to be, is how it went from an idea or something that we thought was amazing and sort of pie in the sky to actually becoming a rig in our parking lot and something that's tangible. So that's from our community and matched by Sutter Health. The hospital and hospital leadership being very forward thinking. Similarly, San Mateo County EMS, and then our ongoing collaboration with San Mateo AMR and the fire departments, the Board of Supervisors, Public Safety Communications, all of the other hospitals in San Mateo County. This is truly a county resource. This is not a Mills Peninsula ambulance. This is something that helps all patients in San Mateo County. and then other MSUs with whom we have great collaboration. We learn from one another as we try to sort of navigate this new world, this new frontier. And like I mentioned, this community resource, this happens because we had community engagement, we have a very forward-thinking county, and adding to that, the outreach and education that we have provided led us to become the first and only Northern California mobile stroke unit. This is a map of San Mateo County, and essentially a heat map. This is from 2021, but the numbers, the map basically is to show you that we touch patients all throughout the county. So there are more concentrated areas. They don't, all the patients do not automatically go to one hospital. They go to whatever hospital they would normally go to using the San Mateo County EMS protocol. But we have been able to treat and assess, diagnose, and treat patients in all parts of the county. So in talking about our clinical operations, really the first step, and before we got started, before we could actually deploy the unit and treat a real patient, we needed to do some training. So we trained first responders on stroke symptom recognition. We wanted to teach them more about stroke than just the pre-hospital scales. We really wanted to expand their knowledge and have them always have stroke on their minds when they're assessing a patient. But just as we trained them, they trained us. So this is their field, this is their world, and a lot to learn. Don't walk into traffic, don't, kind of life lessons that I was getting from being on an ambulance is not normally where I was practicing medicine. It was something new for me. So we trained one another, and it required a perspective shift for sure. When we are activated in the county, we are engaged with the public safety communications. Dr. Gilbert from EMS is going to talk a little bit more about that later. When we are assessing the patient, the assessment by stroke neurology can be in person or via telemedicine. And we are one of the few MSUs that use in-field telemedicine. So meaning that the stroke nurse has glasses and I can see what he's seeing in the field, in the house, assessing the patient right where they are, making a determination whether they should come on the mobile stroke unit or not. And if they are a candidate, if they're taken on board, CT is performed, and then treatment and triage decisions are made. And you may think, well, so you benefit the patients that you transport, but I'd like to put the idea out there that we actually benefit all patients that we assess. And that's because if we assess a patient and determine, no, this is not a stroke, or this is not somebody in the window for stroke treatment, we may actually allow EMS to transport more safely, knowing that that patient is stable and can be transported to the nearest hospital. There's also a lot of benefits for triage in that transport, and I'll talk a little bit more about that later. And then the handoff. So we're constantly communicating. We are handing off between crews, between fire, between the other ambulance crew to the MSU crew. We're also handing off to other hospitals. And all of that relies on open, constant communication, feedback, and being willing to iterate when there's improvements to be made. Our community outreach has really been at the core of our program. We know that we wouldn't have this program if not for the generosity and the forward thinking of San Mateo County and of our supporters. And so we like to do both active and, as I call it, passive education to the community. So we go to events, we allow people to tour through the unit. Actually, if anyone on this call is interested, get in touch with me. I'd love for you to come and check out the mobile stroke unit. When you tour through, when you see it in person, it really does make, it's very impressive. But the passive education, I like to say, is that the back of the MSU has on it the BFAST logo. And it has BFAST and what that all stands for. So we say we're teaching people while we're all stuck in traffic. They look at the back of the ambulance and can read about some stroke symptoms. So some other community events you have here, picture, just team. I had a lot of pictures I wanted to show. We also have done a lot of interactions with media, whether it's been sharing news about our research, or just about great patient cases, we've had the opportunity to share that with the community. So you may be thinking, okay, it sounds great, but what do you have to show for yourself? So does the treatment of stroke patients on an MSU actually provide clinical benefit, or is it just a fancy ambulance to show off that you can fit a CT scanner in an ambulance? And then is this cost effective, right? It's an upfront capital investment. Is this a cost effective way to evaluate stroke patients in the pre-hospital setting? So UT Health in Houston introduced in 2014 the United States' first mobile stroke unit. And this was a concept that was started actually in Germany, in Berlin, and was very successful there with a positive clinical trial, the Be Proud study. And in 2014, Dr. Jim Grotta, as a pioneer in the pre-hospital stroke field, brought an MSU to Houston and started operating it and began the best MSU clinical trial. And over the course of the 6 years, or the next 6 years, 6 additional sites were added, one of which was our MSU in San Mateo County. So this trial was observational, it was prospective, it was multi-center. It's difficult to randomize in a blinded fashion, whether you're on the MSU or not, because it's fairly obvious when you receive your CT scan on board the ambulance, you know what you're on the MSU. But it was an alternating week trial as a way to give some sort of pseudo randomization to it. And it enrolled over 1,500 patients. Of those, over 1,000 were eligible to receive PPA, the clot busting medication. So 617 of those were treated on an MSU, and the rest were treated with the standard approach, a regular ambulance being taken to the emergency department. And we were very proud when the results of this trial were published in the New England Journal of Medicine just a little over 1 year ago. So the primary outcomes, we're looking at 3-month functional outcomes among TPA-eligible ischemic stroke patients, comparing MSU group to standard management group. And the secondary outcomes were cost effectiveness and quality of life measures. So what were the results of this study? So treatment rates first. Patients were more likely to be treated. So almost all patients, 97% in the MSU group, compared to under 80% of patients in the standard care group, were treated if they were eligible. Now you may ask, why wouldn't an eligible patient be treated? It may be that by the time they arrived at the hospital and all of the diagnostics were done, they were actually outside of the window, or their risk-benefit conversation that happened in the hospital ultimately decided not to treat that patient. But we saw that in the MSU group, these patients were more likely to be treated. We also saw that these patients received treatment faster. So this first bullet that I have on here is, really was shocking, I think, even to those of us who were running the trial, who saw the patients. And when we saw all of the data and these results, that 1/3 of the patients in the MSU group were treated in what we call the golden hour of stroke treatment. So 60 minutes from the time of stroke onset, not from the 911 call, not from the time of getting to the hospital, but from the onset of symptoms or the time they were last themselves, compared to only 2.6% in the standard care group. Now, I'm not very shocked by the 2.6%. That's sort of what I would have expected. But the 32.9, 1/3 of these patients on the MSU being treated in the golden hour was really a high point of the study result. We also saw that the median time from stroke onset to treatment was 36 minutes shorter in the MSU group compared to standard care. And when we know that 2 million neurons are perishing every minute that a stroke goes untreated, imagine the difference that these 36 minutes can make. So the first 2 results you may have guessed would be, would come of this study. Well, you're coming to the patient, so of course you're gonna treat them faster because you're there on scene. Do patients actually do better? And the answer is yes. Patients were more likely to be independent. They were more likely to recover being treated on a mobile stroke unit. So for every 100 patients that were treated with the clot busting medication on an MSU, 27 of those will become less disabled had they been treated with the standard approach. So they will be less disabled because of having been treated on the MSU. And 11 patients will be completely disability free. Whereas if they had been treated the standard approach, they would have had stroke disability. So these results were very impressive. We were very happy with these. The study had concluded in June of 2020, and for the following year, we continued to collect cost effectiveness data. So when I say that, what I mean is the healthcare costs, the healthcare expenditures that are incurred by stroke patients, both in the MSU group and the standard management group for the following year, whether that's going to an acute rehab facility, having home health nursing, medical equipment, anything that qualified as a stroke-related cost was included in this. And the question became, are MSUs cost effective? They're expensive, they're fairly expensive upfront, but do they save the healthcare system money down the road? The answer is yes. MSUs are cost effective. So MSUs save stroke-related costs downstream, and there's an ICER, so there's a cost effectiveness ratio, incremental cost effectiveness ratio. And what this means is how much additional money is spent to gain one quality adjusted life year. And for some perspective or some reference, in the United States, something that is under $190,000 per quality is considered cost effective. And something that's under $63,000 is considered highly cost effective. Well, MSUs for all patients in the study were only at $33,000, meaning they were very, very cost effective. If you further drill down and say, let's look at the patients who had no pre-existing disability. So they came into this, either this was their first time stroke or they had no disability prior to entering the study. Those patients, it was only $10,000 per quality. So again, extremely cost effective when looking at it as a whole and considering healthcare expenditures. And this work was largely done by Dr. Suja Rajan at UT Houston as part of the BEST MSU trial. As you can imagine, the ICER was highly dependent on the number of patients that are treated annually by an MSU. You have the upfront capital costs, which is a one-time cost. The more patients that you treat, the more likely you are to improve their outcomes and reduce healthcare expenditures for that many more patients. So we think about future research directions and where can this go? So yes, the MSU is successful and you have it in various counties across the country. Every county is different, and thinking about it locally is important, but thinking about it as a broader solution to the landscape of stroke care is what we are aiming to do. So some sub-studies that are either published or being published shortly from the BEST MSU trial, looking at those patients, those golden hour patients, looking at patients with pre-existing disability and how do they do on the MSUs in particular, looking at averted strokes, patients who would have had stroke on imaging who then end up with no stroke on their imaging because they were treated so quickly on MSUs. And also looking at racial disparities among the MSU treated population. There are other treatments that we are considering or are running studies on using the mobile stroke units. And one of those is an ongoing trial called FASTEST, looking at a hemorrhage treatment that can only be administered in the first 2 hours of onset. That is extremely difficult to do when relying on the regular route of transport. But on a mobile stroke unit, it becomes more possible. Other potential studies for the future would be medications for neuroprotection or adjunct treatments to the clot busting medication. And then when we think about systems analyses that we can do, and some sites actually have done, is where are the optimal locations for mobile stroke units? Mapping the locations of stroke calls, mapping the populations, mapping the high-risk patients, and identifying places that are either appropriately staffed with a mobile stroke unit or would be a good idea to put a mobile stroke unit in that area to better respond to those populations. Additional cost analyses are underway as well as thinking about this from a health equity standpoint and making sure that populations and communities and regions that are potentially under access to care would get something like a mobile stroke unit to sort of level the playing field a little bit. I'll briefly talk about what we have from the Best MSU study, although there's much more work to be done. When we look at the racial breakdown, they separated by Black patients and non-Black patients. We saw that both groups benefited from mobile stroke units. So both odds ratios were, past the 1, including the arrow bars. But we see potentially that there was more benefit for the Black patients. Now, this was a pre-specified sub-study analysis, and there's likely more work that can be done both from the Best MSU data as well as real population data from all of the currently operating mobile stroke units. In Houston, Dr. Grata did a comparison looking at mobile stroke unit dispatches, which is on the left, compared to the predominant race ethnicity by neighborhood, which is on the right. This is in Harris County in Texas. So what we can see is that we do highlight here that the MSU has coverage in areas that have higher Black and Hispanic populations. However, it also identifies areas of need. So areas which may benefit from additional resources like a mobile stroke unit. Similarly, this is the same map, except for on the right, you now have looking at social vulnerability by neighborhood. And so again, would it make sense to put mobile stroke units, several or at least one more, in some of these areas to level the playing field and improve access to stroke care? In Los Angeles, there is the stroke heat map is in the middle. So where are the dispatches for stroke? On the left, we have the areas that are highly, the prevalence of Black or African American is highest, is in the darkest blue. And on the right, we see the patients that have strokes at younger ages, so 50 to 64, as opposed to over 65. And in some of the areas where currently their mobile stroke unit operates, they are capturing some of these high-risk places, but they do see room for improvement. And so when we look at that room for improvement, how are we going to get there? So every county that has one of these mobile stroke units has gotten there, like I mentioned we did, by partnerships, by team building in the community, but it's really been on a local scale and a local level. And so when we think more broadly about how can we expand a program like this, we think about policy changes. So designating mobile stroke units as true county resources, ability to transport patients regardless of which fire company or ambulance company is in that territory. Designating MSUs as a place of service, as a place where medical care is delivered. And there was a win recently, very recently, just about a month ago. Assembly Bill 2117 was signed by Governor Newsom, and this acknowledges mobile stroke units as a place of service. And it also encourages ongoing work for the local EMS agencies, as well as the state EMS agency, to work with mobile stroke unit leaders to expand these programs. When we think about optimizing for local systems, we talk about mapping, like I mentioned, to determine where the best locations might be, and integrating with the healthcare system that we are a part of. And finally here, financial sustainability. So, philanthropy is wonderful, and it's a way sometimes to get dreams into reality for innovative healthcare programs like this, but you need some kind of solvency, some kind of sustainability. And so can we get healthcare insurance payers to start compensating for services that are performed? And there are ongoing conversations about that. As we expand the reach of our mobile stroke unit, and as we expand the concept of what the mobile stroke unit can provide, we think about CT angio and perfusion. So angiography being the ability to look at blood vessels in the brain that are affected during the stroke. This does not delay the treatment of these strokes, but it does allow us to identify and exclude large vessel occlusions prior to determining a hospital destination. It also, if we see a large vessel occlusion, we can alert the cath lab, we can alert the interventional neuroradiologist that there is a patient coming to you who you are likely to take, and we can go straight from the ED into the cath lab. And we have done that and other sites have done that, and it saves a tremendous amount of time when we see good outcomes in those patients. We also can make sure that we are triaging to the right level of hospital, but also that we're not over triaging. Not every stroke patient needs to go to a comprehensive stroke center. If every hospital were a comprehensive stroke center, it would be a different conversation. But figuring out which patients can benefit from staying close to home or close to where the incident occurred, that they had their stroke, versus which patients need to be transferred to a comprehensive or thrombectomy center, that's information that we can get in the field and triage. Expanding to wider catchment areas, Dr. Gilbert will talk about our innovative system for doing this, as well as expanding our hours of operation, and then thinking outside the box, what other neurologic emergencies can benefit from early diagnosis, treatment, and triage. And so with that, I'll end. This is a photo of one of our favorite patients, and I am not just saying that because he's here with us talking on the panel, but we were very lucky to maintain great relationships with the patients that we've treated on this unit. And I think that really is a testament to how special this program is and how personal it really is for all of us. And so with that, I will conclude. And my email is here, and please feel free to reach out with any questions or just want to come walk through the unit.
Thank you so much, Ilana. That was amazing. You're like speaking in our language here for this group. It was everything that we always want to know. And it's just been so amazing to see the work that the MSUs have really busted forward. Like you said, making these dreams come true. And I know that there are some questions coming in the chat. I'll just ask one to build off of what you said with the mobile stroke unit and finding the right place for them. And I always wondered if the right place was really in a densely populated region like San Mateo County, where there's lots of CSCs and PSCs, or if we should actually be seeing these more where you showed on your California high mortality map, Northern California, the places where we have the least amount of resources. I'm curious, I mean, I understand philanthropy brought this to reality, and philanthropy may not be available in those regions, but how do we engage the areas that don't have as many resources, may not have as many donors, but are the places where we need rapid access more, where there are a lack of these centers?
Absolutely, great question. So a couple, I'll address them kind of in order, and I think it'll build. So I too, when I heard the idea, I was like, why do we need this? The hospitals are like 5 minutes away. You can I commuted from one to the other, so it didn't make sense to me. And then I looked at the numbers and I saw that in many of the places where mobile stroke units were, including the ones that were in the Best MSU trial, they were in areas with concentrated amounts of stroke centers around. And still, the patients were getting to the hospital so much faster and getting treated by the time they were at the hospital, that even if you had great in-hospital systems, they were still saving time. New York, which everyone, I think at least being from California, imagines everything's just really crammed together. And so I can't even imagine having one of these in New York. Well, they have two. And yes, they are very effective, and they just drive around Manhattan and they're effective and their patients benefit, and they have the numbers to back it up. So I was impressed by that. That's not to say that you won't benefit a rural area. I think that's more easy to imagine that it would benefit a rural area. You have long transport times, and what can you be doing during that time except for driving? You can be treating the patient, and you can make sure you're taking them to the right place. One thing I'll say for some of the really far out places is that often there's air transport that is needed to take them to a comprehensive or a thrombectomy. And so the benefit of the mobile stroke unit, yes, they would get their thrombolytic faster, their TPA or their TNK faster. It would still be a care coordination to get them then onto a helicopter or a fixed wing to get them to a thrombectomy or comprehensive center, but not to say there's not benefit. And then to your question about how do we get it there, right? So it's proof of concept in an area that we had this very engaged population and this county that was supportive, but how do you expand that? And I think the answer is legislation. I think, and I know that that's slow and that it takes time, but I think that showing that this is effective in these areas where we have had the luxury and the benefit of having these programs, how do you expand that? And let's think outside the box. Why do you need one physician per mobile stroke unit? You don't. I can cover multiple mobile stroke units remotely at the same time and reduce our costs that way. There's ways to do it, but I do think that it's something that needs to be at least somewhat sustainable financially for those areas to justify putting up the capital cost.
Thanks, Ilana. Speaking of costs, Scott, are you on to ask your question about the cost effectiveness? Otherwise, I'll ask it for you.
I am unmuting. There we go.
him.
Yes.
There he is.
Yeah. Thank you.
Maybe you
Yeah,
can introduce who you are when you
Oh,
ask
hi,
your
I'm
question.
Scott Flynn. I'm a medical director at Blue Shield during the day and urgent care doctor by night at Sharp. And I'm a family practice sports medicine trained doc. Question I had was when you did your ICER study or looking at the costs, was it just capital costs you looked at, or did you include the operational costs to the manpower, the vehicle maintenance, all that kind of stuff?
All of it, and those costs were amortized. So when we looked at like the capital costs of, for example, the CT scanner, they would build in that would need to be replaced every X number of years. It actually is, as you can imagine, quite a complicated study, and so the paper is actually still being worked on, despite the data being presented at the International Stroke Conference last year. And so one of the criticisms that we all had internally was that a lot of those numbers were from Texas because they enrolled the most number of patients and their costs were sort of more easily accessible. We wanted to make sure that it really was a representation of all of the MSUs that participated in the trial, because as you can imagine, cost of personnel is very different state to state and can make a big difference. But yes, those were included.
Suzanne is asking, any suggestions for legislation changes, given legislation is a way to spread this?
Yes, I don't know that I'm the best person to tell you in the right words what legislation changes, but I love to be part of these conversations with people much smarter than myself in this field. So I think that the first step is what we've done in California, which is that recognizing that a mobile stroke unit is a place of service. And before entering these conversations, I was like, why isn't that obvious? It's a place that we do medicine, so why isn't it a place of service? I'm learning a lot. So we have to recognize that it's a place that medical service can be rendered and that those services should be billed or able to be billed by the physicians or the techs or whoever is performing those on the mobile stroke unit. So I think that's one. And then I think also some legislation that has to do with how mobile stroke units are integrated into the systems of care. So whether that's the EMS authority or that's Department of Public Health, but figuring out where MSUs live and then working with those people, those agencies to determine what's the best way to regulate these. How do we make it equitable? How do we spread them out? How do we provide the coverage? And doing all of that on a at least state, if not national level, I think is the dream, but we'll take it stepwise as we go.
Okay, next, Ed, you can introduce yourself and you have a couple questions. You're muted.
Sorry. Ed, you're a family physician, part of Palo Alto Medical Foundation, so fantastic work. My question has to do with the patient selection process. I would imagine, could you tell us about how you decide when to deploy the MSU to the patient? And I would imagine, would that differ depending where you place them? So the patient selection process.
Yeah, so Dr. Gilbert is on the call, and he's the EMS medical director for San Mateo County, and he's going to be talking a little bit about our integration with the 911 call system with public safety communications. But what I'll briefly say is that they have an algorithm when to deploy the mobile stroke unit if the call meets certain criteria. Additionally, and where I found a lot of benefit and a lot of joy is teaching our on the ground medics and firefighters that if they respond to a call that's not a stroke, but they realize it might be a stroke, activating us secondarily. Those tend to be more real, pay off more. We transport more of those patients. I don't think that it differs depending on where you would deploy the unit meaning we would still try to respond to those calls. Now in San Mateo County, we found, and Dr. Gilbert will get into the details of the special system we've created to be able to cover the entire county, but that's not possible everywhere. Los Angeles County is a great example, and they're currently working with their local legislation as well as their EMS agencies, of which there are so many fire departments down there that transport, to figure out how many units they need. And it's looking like they might need 7. So different counties are different, and you just have to figure out the timing. You don't want your crew to be waiting on scene for a very long time. But at the same time, there is this perspective shift that the medics have to take, which is that waiting for the mobile stroke unit is potentially like waiting for the primary stroke center to come to you. And if that happens, you're still saving time.
Got it. And can you tell us the capacity of these mobile stroke units? It's like in 24 hours. How many cases could they kind of reliably manage at max capacity?
So what happens currently is we're operational Monday through Friday, 8:30 to 4:30. And I wish that we were operational, 24/7. But when you look at the numbers, there clearly is a nighttime lull in strokes. Because there's a lot of our wake up strokes and then a lot of the evening strokes, but there's that intermediate period where maybe you don't need the MSU to be active. That said, we get about 6 calls a day, and those calls end up being, some are real, some are not. What I mean by that is some are strokes and some are other medical conditions that came out in the phone call to 911 as maybe stroke. And then of the ones that we assess, we transport about a quarter. And so that may not seem like that many patients. That's not our maximum capacity, but we're not missing any calls in San Mateo County. So we're able to cover those. The reason why we might not transport a patient, A, they're not having a stroke, their sugar is very low, there's another explanation for it, some other mimic, or they are medically unstable. So if that patient needs to be intubated shortly, the priority is not a CT in the priority is get to the emergency department and get treated by an emergency department physician and get stabilized. And then let's worry about your stroke. So those patients we wouldn't transport, but the others we do. If we think we can help them, even if it's just, severe headache and it might be a bleed and I can help lower their blood pressure, that's something that the mobile stroke unit can offer that a regular ambulance would not. So we do transport those patients as well. I hope that answered your question.
Thank you.
Sure. And we have Dr. Brommer with the last question for this section before we move to Dr. Gilbert. Go ahead.
Thank you. So thank you very much for a very exceptional presentation. Number one, I would like to order one of these MSUs right now. So give me the form for it and we'll order it. But more importantly, as we look at the state of California, how many would we have to order for the state of California if we go through legislation? Do we need 1 per county? Obviously, LA might need 7 or so. Would 200 of MSUs cover, in your mind, the state of California if we start talking about legislation and funding?
Well, I'll address your first point first because it's easier, but there's about a year lead time to get an MSU. So you better hurry because the parts are in high demand. But to answer the second one, I'm not sure. I don't want to say, yes, I think on the surface, that sounds like a reasonable number. Los Angeles being so highly populated, so concentrated, and that their county could be covered based on their analysis, which was sound, with 7, that does seem like 200 seems like it should cover the state. But that's an analysis that I actually hope to do and hope to partner with others in that space to be able to do intelligently and come up with that number of how many would solve the problem and how many would be, and then how would they be integrated, right? Would each one be its own county? Would each one, right now they're single hospital affiliated because the physicians that staff them are in some medical group and the nurses and CT techs are employed by a hospital. And so thinking outside of that and how can we have these staffed more by like a public health, force is really the what I want to work on. That's what I want to do.
Thank you.
Thank you.
Thanks so much. I think we can, I see Dr. Gilbert's on the line. Hey, Greg, it's good to see you after some time.
It has
Dr.
been quite some
Gilbert,
time. Good
yeah.
to see you again, Raleigh.
Great to see you. Used to be a Stanford ED professor and has really taken a lead with the emergency medical EMS medical director for our region in San Mateo County, as well as a leadership role at Mills Peninsula. And as Ilana has mentioned, has been an innovator on multiple levels, but including the stroke unit, mobile stroke unit, and getting this integrated system to function. So I'll let you take it from there.
And I'll tell you, I wasn't drinking the Kool-Aid when Ilana and Joey English kind of first sold this idea, and I've come a long way from a naysayer to a believer. So I'll hit my slides, but obviously I have a lot of. I wasn't sure what exactly you guys would want to ask questions about, and I can maybe answer those questions because I do have a lot of information that I'm aware of. So why don't we go to my slide set? And so next slide. Wow, that's exciting. So yeah, Ilana and I have kind of been doing this case study and talking about how the hospital or how the county and the mobile stroke unit need to work together. I can tell you that there are some counties out there that actually have purchased a mobile stroke unit, didn't talk with the EMS agency, and then had to let it sit on their driveway while they waited to get the county up to snuff. So the first thing you need to do if you're wanting to purchase a mobile stroke unit is to reach out to your county's EMS medical director if you're in California, or state EMS medical director if you're in some of the other ones, because the other famous thing that we say in emergency medical services is if you've seen one EMS system, you've seen one EMS system. So it always leads to very interesting politics when we go forward. So next slide. Keep going. There we go. And so, yeah, so as you heard, the mobile stroke unit is this novel and innovative idea. It was started internationally and at University Houston, Texas, Houston. And it really brings the hospital to the patient. And the other thing that we've really seen in San Mateo County is in order to get patients the drug that they need to fix their stroke, you need to have parallel processes. And so things need to be happening all simultaneously at the same time if you're going to get drug on board these patients the quickest. And then interestingly, the most recent studies that are coming out, yes, time is brain cells and it's 2 million of them and for each minute. And it really does make a huge difference. 10 minutes can make a huge difference in stroke care, whereas in cardiac care, it's not as big a deal. Next slide. So what happens after you call 911? Well, so the call is received by dispatch, and that complaint's put through what's known as an emergency medical dispatch set of cards. And so based on that card, the EMS agency will deploy an ambulance in your direction, and they make sure that it's the correct resources that are deployed. I will tell you in San Mateo County, we do send all ALS responses, but there are some counties that will do a BLS response, a tiered response, either BLS, Basic Life Services, or ALS, Advanced Life Services. And then an assessment's done on scene, and based on what signs or symptoms the patients are having, they will transport to the appropriate hospital. So if the easiest way to think about this is, if it's a trauma patient, obviously you're not going to go to a local community hospital, you're going to go to a trauma center. Likewise, if you're having a heart attack or a stroke, you'll be going to places that can deal with those things. In other words, the idea is that we get the patient to the right place the first time. And so that's where the protocols then help guide where the patient's transported. Next slide. So the way the MSU is deployed is, again, we talked about this EMD card. And so if the questions lead to being on the stroke card or the headache card, then the mobile stroke unit's auto-activated to that location. So they will be deployed in tandem with a regular 911 ambulance. And then the other way that they can be activated is two ways. One is they can be kind of listening, and if the dialogue kind of sounds like it's going to be a stroke, they might start sneaking that way. And ultimately, obviously, the paramedic in the field, if they think this is a stroke, can then activate the mobile stroke unit. And that would start moving them in that direction. And then, so the mobile stroke unit catchment area is based upon response time and destination hospital. So we know that from 911 call to arrival of the EMS system is usually about 8 to 10 minutes. They will spend then on scene roughly about 20 minutes, but usually less than that, 15 to 20. And then the transport time to the appropriate hospital is somewhere in the neighborhood of 12 to 15 minutes. And so you can imagine if you get that mobile stroke unit to arrive within the first 12 to 15 minutes of care, you're actually shaving off 15 to 20 minutes of time that can't be competed with at the hospital. So that's why I've drank the Kool-Aid. Is the other thing that I've learned as a doctor in the emergency department in my 20 some odd years of practice, I've probably treated one patient the entire time within what's called the golden hour. And the golden hour is symptom onset to drug going in before 1 hour passes. And so, like I said, in all my years of working in the emergency department, I think that's happened once. And I can tell you kind of in the first 2 to 3 months, it had happened like 4 to 5 times on the mobile stroke unit. Next slide. So this is kind of the protocols that are set up in the EMS system. And again, so the 911 call comes in, they choose what they think the primary diagnosis is or primary complaint is. And so if they think it's a stroke or a CVA, they kind of go to this card. If the mobile stroke unit is available, you'll see a very similar card. It's called A34. Next slide, A34T. And so that's for the mobile stroke unit. And you can see that the pathway is a little bit different. But again, you can kind of see how it is that, sort of all these things come to fruition and ultimately leading to treatment. Now, again, I mentioned that if you've seen one EMS system, you've seen one EMS system. So you can see in the upper right-hand corner in the teal blue, and when I say you can see it, you'll just have to believe me because I know it's super small. But essentially it delineates who our primary stroke centers are, who our comprehensive stroke centers are, and who our thrombectomy capable stroke centers are. And so if you're thrombectomy capable or comprehensive stroke centers, you can do what's called thrombectomy removal. In other words, patients with large vessel occlusions, you can go in and remove the clot beyond that 3.5 hour window. So you'll, or beyond the 4.5 hour window. So you'll notice in the yellow box just to the left, we use time as cutoff in our system to determine where a patient will go. So if you're 3.5 hours or less, you'll go to the closest primary stroke center because that's usually going to be your shortest transport. And they should be able to get drug on as quickly as possible. If you're in the beyond the 3.5 hours, and I really wanted to go out to 24 hours because essentially these are all patients that are in the extended window. They'll go to a thrombectomy capable or a comprehensive stroke center because if they have something that's going to be treated, it's going to need thrombectomy, and it's going to require going in and removing it. Science has changed a lot, and I will tell you that it's becoming less and less about how much time since your stroke, and it's now becoming more about how much peripheral circulation your brain's receiving. And so when you arrive at the hospital, they do a fancy thing called a rapid CT scan, which kind of looks at the amount of dead brain tissue versus the amount of in jeopardy brain tissue. So even if you're 16 or 17 hours in, and that brain tissue that's still survivable is sort of known as penumbra. If you have a lot of that, they actually may give you drug in those instances because you actually have a pretty good collateral circulation that hasn't allowed that much of the brain to die, and then less likely to actually hemorrhage when getting the thrombolytics. So it's becoming more about collateral circulation and the CT scan MRI results and less about time, but more to come on that as more studies come out. And so the timeless study, I think, is currently being done at Stanford, and we'll know more when that kind of comes to fruition. Next slide. So obviously, not obviously, but the response time of the mobile stroke unit when we plug it into the GPS can be about 10 minutes circumference around the hospital of which it's located on. Well, as you know, that won't get the best coverage for that mobile stroke unit. And how can we make it a little bit better? So what we did is we actually created rendezvous points. And if we go to the next slide, you can kind of see these different rendezvous points. So when the mobile stroke unit is kind of positioned in the north, you can see it there next to Hillsborough. And when it's positioned in the south, it's actually positioned down there near Emerald Hills. And so you can see that it actually expands the area from which it can respond to and actually meet them halfway on their way to the hospital and rendezvous, again, cutting off some of the time that it would normally take to get to the hospital. And so this is typically what the mobile stroke units in many of the other cities are doing, is they will meet the other, they have what's sort of like a hub and spoke model, and they'll run towards wherever that patient's coming from and cut the driving distance in half. And again, the studies out of those centers has actually shown that again shaves off those valuable minutes that we've already talked about. Each minute that you're delaying is 2 million brain cells. Next slide. And so just so you know, yes, we have been able, so this slide shows obviously the dark blue is right around where Mills Peninsula is, but this was early on when it has most of our early responses, but as we've moved to a north and south, the blue expands and covers all of San Mateo County. And you can see the dots in the center with where we've given TPA. And so again, you can see that it's been happening all over the county and that the rendezvous system's working and that we are able to kind of cover all of San Mateo. And if you had to ask me how many MSUs we'd need in San Mateo to cover the whole county, I would tell you 2. There's about 33, I think, LEMSAs or local EMS agencies. So if you multiply that, I think 200 is probably about the right number. That way, if any break down, you can always, send them a new. But anyways, I think that's it with my slides. And what kind of questions do you guys have? Look at that, I left them speechless. That's awesome.
Thanks so much. And people can put questions in the chat. How, in the cost effectiveness analysis, is the deployment, I guess it's the same thing, right? Deployment of the second ambulance, that would have happened anyway. So that would have happened anyway. So and then, the coming to the emergency department, we look at things that are parallels and you take those out because it's not sort of an additional cost that's brought by the mobile stroke unit.
Yeah, the more mobile stroke units you have, actually, the cheaper it probably gets, as long as you don't staff it with a neurologist. If you staff it with a neurologist, that's a problem. But if you do telemedicine with the neurologist, they can cover 3, 4, 5, 6, 10 mobile stroke units, just like sort of the Kaiser system, right? They have 2 neurologists, stroke neurologists, that covers all of Northern California. And for the most part, one can cover it. And then if there's any overflow, they add a second. So it can be very cost effective the more mobile stroke units you have.
And I see a message from Hattie that was to me to please elaborate on the glasses that the nurse wears that allow me to see what the EMT sees. So it's actually the nurse, the stroke nurse wears them. And it allows, they're called real wear glasses. If you've seen Google glasses that were, a thing for a minute, they wear those and there's a camera on them, a little monitor where he theoretically could see me, but he's focused on, the firefighters and the patient. But anything he sees and hears, I'm able to see and hear. And I'm able to then communicate, ask questions, and get the story. And that helps make a determination of whether that patient should come on board or not. We're in the process right now of vetting a better technology, a little bit less clunky, a different brand, but the idea is the same. And then we have MiFi devices to extend our internet signal, our cell signal to internet signal to be able to power those with connectivity.
Patty, any other questions?
I just think that in the interest of time, we should probably hear our wonderful patient story from somebody who had a great outcome as a result of the mobile unit. Ilana, would you like to introduce your patient, please?
Sure. So Mr. Madduluri, he'll tell you his story in detail, but we became acquainted in a moment of panic, which is not really when you want to meet somebody, but we responded with the mobile stroke unit fairly early on to his place of work. And ultimately we found that though his symptoms were subtle, he was definitely having a stroke. And it was a teaching moment for the MSU crew. It was a teaching moment for the fire medics and the AMR medics that came to respond. And it was a really amazing save for Ram. And he can tell you more about, exactly what happened that day from his perspective, but I'll say that we've been really lucky to have been connected with him and to have, first of all, so glad that he recovered as amazingly as he did. And truly due to the mobile stroke unit being there. I really do believe that. And he's then become our spokesmodel. So he can give you his story. Thank you, Ram, for coming.
Well, thank you, Dr. Spokoyny. My name is Ram, minus 72 million neurons, Madduluri. So basically, I was rescued by Dr. Spokoyny's mobile stroke unit in Foster City. Interestingly, what I learned subsequently, and I'm jumping myself here, is it was on a trial with the A/B testing. It happens to be happened to be on A group. And luckily that week they were on. And I was working in my office and I'd gone, it's a 6-story building. I was on the ground floor picking up some lunch. I'm climbing up the stairs as I normally do. I felt a little bit of odd sensation in my throat and I thought I got a sore throat. And I had never taken a day off in my life for sickness, 30 plus years of working and never took a day off. So I said, I was walking up, I was thinking it's a slow day. And I thought, hey, you know what? I go home. Today's, and claim I got a sore throat and I just drive home. I walk upstairs, tell my manager, walk up to his office and say, Patty, I'm taking the rest of the afternoon off. I kind of got a sore throat. And he was typing at his keyboard, standing up, and he looked up at me and said, Ram, you don't sound good. And he didn't know anything else other than just say I didn't sound good. And then at that point, I realized I may be slurring, but I had no clue that I was having a stroke, and neither did he. So this goes to, I guess, one of the points of recognition, awareness in the general population about stroke and what are the symptoms if somebody is having a heart attack, they're clutching their chest or whatever. I guess we see a lot of that in the movies and so on. So general populations are aware. In case of stroke, he wasn't, and nobody in my office was. And luckily for me, he said he instructed our admin to call 911. And lucky for me, and I would say I'm extremely lucky person. I should have bought a lotto ticket that day, but I was too busy in the hospital. But my luck is that there is a fire department right across the street from my office. They responded within probably 3 or 4 minutes. They were in my office and asking me, going through the triage process. And I was actually pacing up and down and saying, why are you making such a big deal of this? I'm feeling just fine. I'm walking, I'm able to comprehend and do everything that I was able to do. And they said, no. They started asking me a simple question to see if I'm able to answer properly. And of course, this parallel processing was happening in the background. I wasn't quite aware of all these things at that time, that actually the calls went out to 911, to ambulance system, to, obviously got to MSU. And, they came by very quickly, probably within 10 minutes, I guess they were there, or maybe 15 minutes. And they took me, the emergency staff just took me in a gurney. I said, I was totally embarrassed to be taken out of my office in front of all my colleagues in a gurney, It's a thing that one can never imagine. And I was embarrassed. I said, let me walk down, They insisted I get on a gurney and, be taken to the ambulance. And the moment they took me down to the first floor, the entrance of the building, of course, MSU was already there. Dr. Spokoyny was already prepared to receive a patient and asking me questions and, going through her process of the triage. And believe it or not, within 36 minutes, I think Dr. Spokoyny has those numbers more clearly, 36 minutes from the time the call went out to the time it was actually, I had a CT scan done and she determined that I need to be given a TPA intravenously, and it was given to me within 36 minutes. So, which is amazing considering it takes 20 minutes or 25 minutes in San Mateo County to get from my office to the hospital. So unless the ambulance was literally in the neighborhood, they really could not have done. And by the way, my office was actually outside of their coverage zone at the time. It was a South San Mateo County, but it was not yet in the trials. But lucky for me, as I said, they decided to take the call and drive across the Route 92 that was dividing the San Mateo County, and drove across to pick me up. So I'm totally amazed looking back. I've been having all these conversations, and I was totally amazed at how quickly the hospital on the wheels got there. It's not a small motorcycle or something, just zip through the traffic and get there. But it was quite amazing, and I'm a living proof. The good news of this is because I only lost 72 million neurons, I was able to go back to work the following week. That was amazing. And when I talk to people about it subsequently, I've been talking to a lot of people, both within my office and outside, and they're amazed that I could recover this quickly. And I was actually fully functional, the following week, except I was feeling a little weak. I was wearing a little jacket, even though it's in summer. I was wearing a vest for most of the summer, but other than that one thing of me feeling a little cold, I was perfectly functional. I was, and I could not, only one thing was like, I was told I cannot drive for 2 months. So I was actually my wife was dropping me off at a train station in Santa Clara and took the train to, Hillsdale train station, and then taking an Uber to my office. So I was doing all this within a week of, getting treated for the stroke. So yeah, it's amazing. I'm eternally grateful. I wish this facility, more than anything else, having gone through this, I wish this facility was available in more places. I've talked to several stroke patients subsequently, and they always say, "You are lucky. I wish we had that. I wish we had that." And that is something that I think, as Dr. Gilbert mentioned, of course, Dr. Spokoyny mentioned, is legislation is the way to make it available for general public. We are a relatively rich county here. And Bay Area is a rich county. We can, afford the cost of care, cost of having the mobile stroke units and other facilities. Not all the counties, as I've driven through California recently, Northern California. They deserve just as much as we do in terms of the care. I wish we don't have the donorship there. I wish we could only provide such services through legislation. The government is more of a policy decision than anything else.
Well, the good news is we have a few policy-oriented people here with us listening to you today. And indeed, we have Dr. William J. Balmer, cardiologist in the Sacramento region, who is the chairman of the Heart Attack and Stroke Prevention Comprehensive Plan for coming up with a plan for the next 10 years for the state, for the California Department of Public Health. Bill, do you want to just comment?
Well, number one, thank you for a very enlightening story. We certainly appreciate that and empathize with you for all that you went through. The question I have is, who called the MSU? In other words, was it your boss? Was it the first EMS person on site? In other words, when we talk about activating in parallel quick response, we have to train the people who are going to be first exposed to you to make that first call. In your situation, who was the one individual who made that decision, hearing your story, to activate or call the MSU unit?
So it was my manager he knew there was something wrong with me. That's the only thing, that there's something, he didn't know what that was. So the only thing he thought of was call 911.
So I can jump in, Ram, and help answer, because this is a great example of when training our first responders really pays off, because this call did not come out as a card 28 or card 18. The complaint was, I forget if it was like trouble breathing, because trouble speaking would have activated us. It wasn't something that triggered the automatic call. And what happened, as Rob mentioned, is that the fire department was literally across the street. They got there within, a couple minutes, 2 minutes, and saw that actually it was trouble talking. And they had just gone through training with me, looking at, what are some stroke symptoms and how might those present, and what is difficulty with language expression versus language comprehension. We went through all of that. And this medic said, I don't know, this sounds like it could be MSU. And so they activated us through the county. And when we heard the call, you never know. And so we said, yeah, let's go, let's see. And we showed up and we said, yes, not only is there trouble, with language expression, but there's a facial, we're finding all these other symptoms that were so subtle. And we find often, and this is why stroke is such a difficult thing for activation, because a lot of times the strokes that we have make us unaware of our deficits. And so we rely on those around us to have to say, so Ram's manager knew something was wrong, but Ram was complaining of like, oh, there's something in my throat. And so when you hear that, it doesn't lead to an automatic activation. And that's where that extra, education comes in.
Now, so educating those EMS people is imperative for this program. Do you have the ability with your EMS communication to get a FaceTime or a direct communication on site with your EMS people? Because that could, I think, enhance their ability to facilitate quick referrals.
So what we recommend, so we don't have telemedicine on every ambulance, but that would be a way to do it. The way that we've done it instead is that even if you suspect, even if you think there's a small chance that this might be stroke, I'd rather you call us and have us come assess and say, no, it's not a stroke, than have you not activate us. And then we realize later that we've missed a patient. And I think we've been pretty successful in doing that. And what we've also found is that I get a lot more calls from medics that have done the training, the stroke training and the lectures, than I do from the other ones, because they've heard me talk about this over and over, and they hear about these symptoms. And they also have heard that we want to know about every call, just call us. And that message, a simple message, that gets through.
And Ilana, did you want to mention that we did actually try to do telemedicine?
Thank you, yes.
No worries, I got you.
When I was at Stanford as a stroke fellow, I did a project with an emergency department physician there who was interested in putting telemedicine onto a regular ambulance. So we worked with Woodside Fire, and a couple of things came out of that study. One is we saw that the connectivity is terrible everywhere, but especially in Woodside. We might have not picked a worse place to trial this because there's just no service. But the other thing that we learned was that when I taught them, so we used the NIH stroke scale to do our stroke assessment in the hospital, the stroke physicians do and the ER physicians do. And we taught the medics a modified NIH stroke scale, not with the expectation that this becomes their assessment, but with the understanding that I really wanted them to be able to perform a more thorough neuro exam than what's dictated by some of the pre-hospital scales. Some of the pre-hospital scales will look at facial droop, arm weakness, and speech. And a lot of times you have other more subtle signs and symptoms. And I don't need you to localize it and tell me what vessel you think is affected. It just needs you to activate the MSU. And I think by doing that training, what we saw was that they were more than capable of learning additional stroke in neurologic exam. And then I think the translation to a program like this would be seeing something abnormal there and activating the unit.
And then I think the other key aspect that Ilana would do she would take them to, I call it a dog and pony show. She'd bring the MSU to each of the different fire stations and kind of show them what it could do and what it was all about. And then also kind of, we do, I don't know, 6 different cases or something.
Yeah.
Ilana, I want to ask a practical question. That's a lot of time and investment to be educating, to be doing this in addition to your clinical role. Is that also supported through the philanthropic dollars or through mills? Like, how does this work supported?
Yeah,
beyond just the unit?
Exactly. So there's the unit and there's the clinical staffing time. And then in addition to that, I have a medical directorship that's supported through the hospital essentially, and through some from the philanthropy funds. But I think that when we look at how does this expand, because this was a start the program kind of thing. But when this expands, it's very feasible to think that the lectures that I give to EMS, they're already there's videos of 5 different videos of them that can just be sent out and can be done virtually with less of that, reliance on one person physically going to all of these places. That said, when you're starting this in a new county and a new place, you really do need, and you rely so much on those personal connections and on when people meet you and see your passion for the program and your desire to help stroke patients and help your community, that is infectious. As opposed to hearing it, oh yes, mobile stroke units help and they're cost effective, we're gonna do one. You're not gonna get the first responder buy-in. So that answered your question, but then to say there probably is a role for outreach in every program to be supported by the program.
Thanks so much. And I was just thinking that too, that there's probably indirect benefits and indirect education to all the EMS who gets this kind of education. And hopefully it's spreading over into our county too, because I think for so long people didn't believe we could train EMS on more advanced stroke education and recognition. But I think that's in and of itself probably a paper worth sharing.
Absolutely. And I'll just add one last thing. I know I'm taking a lot of time, but in training EMS, and we can do the exam, it's also getting this perspective shift of they want to package up the patient and drive. They do not want to stay on scene for 1 second more than they have to. And when you tell them we're on our way to you, don't worry, we're coming, there needs to be this total mindset shift to say you are coming, but you're not just another ambulance to continue the drive. You are a CT scanner, a physician, a pharmacy, and a lab that can treat the stroke patient. So getting that, I think that has been very effective, like Dr. Gilbert was saying, in going and showing them the unit and really realizing it's not just a souped up ambulance. There's much more to it, and it's the whole program.
Great. Okay, well, I think that we can actually introduce Chuck Toeniskoetter and Noemi Conway, who, it's actually perfect because you're talking about mapping in the county and knowing where all the units are and just having easy access for providers, but even for patients to know what their resources are. And so Chuck, where did he go? He is a stroke survivor himself. And Hattie, are you going to introduce? Go for it.
Well, I just wanted to say that it was Dr. Joe Sky who had the brilliant idea of bringing these two contiguous counties together to talk about their different approaches, because there are probably things from both counties that can help each other. Dr. Joe Sky, do you want to say anything in introducing Chuck?
Well, sure.
Oh, he might be freezing.
Hattie, I'm not sure that that this idea is anything that anyone else hasn't thought of. Is my sound not
freezing. Good? Yeah, Joe didn't split his line with the phone this time, I think. But yeah, we've been having connectivity problems. Gee, when Chuck and I were trying to talk about planning this program, we kept losing signal. So that's one potential challenge to how the telemedicine would work. And I don't know, we can talk about that in the Q&A afterwards, but Chuck also had an amazing experience with innovation, but this was more than 20 years ago, and I'll let Chuck tell his own story. But as a Stanford MBA and an engineer, after he recovered from his stroke, he was just dedicated to trying to bring the best of stroke care to Santa Clara County. And in addition to being the CEO of multiple companies, he started the Stroke Awareness Foundation. And with that, I'll just say, next slide, let's go to Chuck Toeniskoetter himself. And how about if Chuck introduces Noemi when he's ready, and we can just bring the slides down now and focus on Chuck. Welcome, Chuck. Thanks for fitting us in, and please unmute yourself.
Done. Thank you. That was a very interesting talk on the mobile stroke units. We've been following them for quite a while, and I thought the information that was disseminated today was really a particular use. So thank you very much, all of you, for that. Hattie asked me to talk about streamlined stroke care in our county, Santa Clara County. And let me go about it maybe this way and with our Stroke Awareness Foundation. It's a little bit different in some respects, and others we're getting really to the same place. But a little background real quickly. Our Stroke Awareness Foundation was formed about 20 years ago in 2002. There were 3 stroke survivors. They were just dedicated to streamlining stroke care in Santa Clara County, which, as you all know, we have about 2.5 million residents here. And we have probably 10 strokes a day that have to be taken care of in this county on average or more. And we formed this foundation in the basement of Good Samaritan Hospital, like every good high-tech company gets started in a basement somewhere, with a retired businessman, then vice mayor of San Jose at that time, and myself. And again, all of us were stroke survivors. And it was obvious to us in those days that the stroke care was not very significant, really. It was actually, I think, kind of prehistoric in a lot of ways. And I'll describe that, why I say that in a minute. But it was my stroke experience that really became the foundation of our stroke awareness plan to change and improve stroke care in our county. And this is my story as a little bit of a background. Hattie, am I on or are you on? I just want to show some people something here in a minute.
Well, you're definitely on. I just
okay.
had to pause to sneeze. Sorry.
That's all right. No, the reason I wanted to do that was my stroke took place at 2:30 in the afternoon on the 23rd of December, right before Christmas, 2000. And I had a massive stroke in Bear Valley, California. And if any of you, when you look at that first chart, or one of those first charts that came up, the outlying areas in the state are the places that are most difficult to take care of any kind of an emergency, and especially one of stroke, because Bear Valley is at 7,200 feet. We had 5 feet of snow on the ground, and it's extremely isolated. My stroke was interesting, is different, than Ram's. If you drew a line down the center of my body, the right-hand side was totally gone. Face was gone, speech was gone, right hand was gone, right arm was gone, right leg was gone. I mean, I fell over, basically. I had to hold on to something to stand up. It was a massive stroke. It was a big one, and it was very noticeable, except to me. I had no idea what was happening to me because I didn't even know anything about the signs of stroke. We'll talk about that in just a second, where our foundations kind of come from. Fortunately, there was a nurse up there. I had the search and rescue team, and she recognized it and called an ambulance and a helicopter. Thank heavens they did. And as they were looking at, the ambulance operator said, "There's too much time to get you down to the hospital, the closest hospital." And the helicopter was the only really way to go. So they piled me into that in literally 5 feet of snow. And I didn't know why, but the helicopter wouldn't take off. The rotors were spinning, the snow was flying, and I'm lying in there, and I think I could see all this. And I'm wondering, what in the world is going on? Well, here's the next piece of information, or piece of all of this that meant a lot to us in our Stroke Awareness Foundation. And that was that nurse was standing on the runners of that helicopter, would not let it take off until they redirected me, not to the closest hospital, but to the right hospital, which in those days happened to be Sutter Roseville. And with that saved my life, because I did get TPA, believe it or not, in that isolated location within 3 hours. And after two years of hard work, I got 98% recovered, and I'm back, functioning the way I did in 2000, before 2000, when I had my stroke. But all those lessons learned, we then applied to Santa Clara County, and I'll get into that in just a second. But I want to remind everybody, of course, you all know, but in those days, I mean, there were no certified stroke centers. There were no really stroke care, as I say, I think was in a back rooms. It really wasn't very upfront. And I relate that to my mother-in-law, who had a stroke in the hospital about 9 months before mine. And I remember the thing they said to her was, "Get her ready for rehab tomorrow." That's the answer. There was no checking on, no CT scans, no TPA, nothing. And she lived in a wheelchair for the next 7 years. And I fortunately, because of what's happened, because of the luck that I had that day, and we've incorporated into Santa Clara County, we think we're making a big difference here with stroke care and getting people back to their normal lives. Now, with my story, again, we set a set of goals with Stroke Awareness Foundation that have proved out to be very helpful. One, we wanted to get stroke centers into Santa Clara County. There were, as I say, there were none, and they were very difficult to get in those days that just weren't licensed. We got the first one in California in Santa Clara County, and they happen to be Good Samaritan Hospital. Today, we have 10. We have 6 primaries, 3 comprehensives, and 1 thrombectomy capable hospital in our county, which is terrific. The next thing, because of the redirection I described to you, and the luck I had of going to the right hospital and not the closest hospital, which was a good one, by the way, but it would not have been right for stroke care. We got ambulance redirection first for the primaries, and then we got them for the comprehensive. And we had to work hard to get that. We got it. We got a lot of cooperation. And today it's just been a godsend for stroke care in our county and the improvement of stroke care. Our focus from there was not for taking care of stroke victims after they have their stroke, or even trying to get people to change their way of life. We early discovered that that was going to be a very expensive, very hard thing to do without much results. So we focused on a different area, and that is public awareness, the signs of stroke, where I have my engineering degree from Notre Dame and an MBA from Stanford. I had no idea what the signs of stroke were. Well, we wanted to correct that in our county. And fortunately, we have raised over $5 million in 20 years to do just that through newspaper advertising, radio advertising, social media, et cetera. And it has made a big difference from the stories that we receive from people who've had strokes, or people who saw someone have a stroke and that were having a stroke, and knew exactly what to do with it. We've also developed a stroke app, and we have thousands of downloads of these apps. And this app is really interesting because not only does it say where the stroke centers are in our county, but anywhere in the United States that you are, when you hit this, bring the stroke app up, it'll tell you the closest stroke center, certified stroke center, and give you a map to how to get there. And you can tell the ambulance operator, because they don't have redirections in a lot of major cities in our country, and they will take you to the closest certified stroke center. I got great stories on that one, but I won't bore you with them right now. The next thing we've done recently, which is going to be, we're really in the middle of it, Noemi will talk about this in a minute, is we've gotten into an ethnic outreach program. You know, we've got a lot of the Caucasian English-speaking population really almost is a minority in our county now. So we've done everything with our stroke app and all of our social medias and our outreach to reach the Spanish-speaking, the Vietnamese-speaking, and the Chinese-speaking communities. And it's having an impact. And we have ambassadors, some of which are board of supervisor members, some of which are council members, some of which are business people, some of which are all different backgrounds to help get this message out, the public awareness of the signs of stroke, getting to an ambulance and getting to the hospitals. Maybe someday it'll tie right into a mobile stroke unit, who knows? And then we do track the Santa Clara County stroke statistics quarterly. We get real good information, which we really appreciate from the county, to try to set our targets and the things that we can do to have the biggest impact possible. And finally, we constantly are monitoring these new stroke care improvement ideas. We have 3 advisory board members, Dr. Albers from Stanford. You know Dr. Albers, he's the best. Dr. Sachdef from Good Samaritan Hospital, and Dr. Bandari from, he was with Kaiser, he's now retired, but he still advises us when we need help in finding better ways to suggest handling our stroke victims in our county. One of the things we're following, we're not sure where this is going, but it's a device called Mind Rhythm. It's made by Mind Rhythm, and that is a portable, disposable, Tiara-like headset that in the EMTs in the field will be able to use something like this. Hopefully, it's going to happen to determine whether a stroke victim is having a small vessel occlusion or a large vessel occlusion, so that it can be taken either to a primary or comprehensive even more accurately than just trying to use BFAST or the other qualitative things that they use now. certainly mobile stroke units we're following, and we will continue to do that. And certainly the longer time for stroke care gives us a lot more flexibility in our suggestions for stroke victims in our county. So our Stroke Awareness Foundation goals are really very simple. They're to continue to improve and streamline our stroke care in our county. And if you don't mind with that, since I know the time's getting short, I'd like to turn the mic over to Noemi Conway, our absolutely invaluable Stroke Awareness Executive Director, who kind of can take us through some of our current and exciting programs that we have in place. Noemi?
Thank you, Chuck. Thank you for having me. Hello, everyone. Well, let me play this for you. Chuck shared some about our history and purpose, and I would like to run through some specific ways that we carry out our public outreach. If I can get my slideshow going. Can everybody see my screen?
We can see the first slide, and here it's turning into, I believe, what you want it to be. Yeah, good.
Thank you. So, leading you through the specific ways that we carry out our initiatives, what we like to do is educate all of our community members, respective to their language and culture, on what stroke is, understanding that it's treatable, and knowing how to recognize it, and most importantly, knowing what to do when a stroke happens. So like Chuck mentioned, fortunately in our county, in Santa Clara County, all 10 hospitals are stroke centers. So we have excellent stroke systems available to our residents. But our data shows that less than half of the stroke patients reach ER in time for under the 4.5-hour window in time for treatment. So we know that there are treatments available beyond this window, but we still know time is a critical factor in ensuring positive outcomes. So in the past 18 years, we really focused on English-speaking public outreach, but we understand that there's a disproportionate number of stroke cases through ethnic communities, and these communities lack access to information and health resources. So many stroke cases can go untreated, unreported, and our aim is to raise stroke awareness to these diverse populations and improve stroke outcomes. So following are some examples of our outreach. So initially what we did is we took the key stroke awareness information, the Be Fast message, the fact that stroke is an emergency and the action to call 911, and we translated this information into 5 additional languages on our website. To drive traffic to these language-specific web pages, we started a multilingual campaign, especially in the Spanish language, being that Spanish is the most prevalent second language in our county. And what we did is we utilized predominantly digital networks, digital media, social media, some radio, as well as print. What we try to do is find a specific mix that is chosen by the habits and the most popular media outlet used by each ethnic group, and also create educational material that speaks to that specific culture. And being family is a very important part of Hispanic culture. For the Spanish campaign, we chosen the Be There for Your Family slogan, which ran for about 5 months on multiple networks. Our outreach is very data driven, so we really track what works, what doesn't, and make sure we shift and pivot to the best performing media. And so from our campaign that ran for 5 months, just to kind of give you general numbers, we had about 22 million impressions. That is how many times we served this ad. We had 30,000 banner clicks, 46 seconds spent on our page. Even though that may seem like not a very long time period, when you consider how long 46 seconds is and reading the simple messaging that we are serving, it is really doing its job. The Spanish campaign led us to nearly 20,000 visits to our Spanish specific landing page. And these visitors, we know there are many more that didn't do the click, but read the message. So this work has led us to community partners that really believe in what we do. And thanks to their generosity, we were able to continue on to Mandarin language. And you see an animated ad here in Mandarin that shows you stroke signs and symptoms, and as well as promotes the app. These messages are actually currently running in the most utilized publication in Chinese community, which is Tsingtao, and it's a digital issue doing really well. In a similar way, we have Vietnamese. Here you see both animated ad and a static, what is called a static ad, also communicating the basic information and just the importance of understanding that stroke is an emergency. And when people see the sign and symptoms, we urge them to call 911. Here is an example of our Vietnam daily publication. And as I mentioned, this is our current program running since about 4 months ago. And here's Mercury News. What we do with the Mercury News is we actually choose populations that are running their language on their Google in their native language. So we are actually targeting the Chinese as well as Vietnamese population via Mercury News. Altogether, we've so far received about 10,000 banner clicks on our 20 million impressions, about over 10,000 visits to our landing page, really trying to penetrate the community with our messaging and kind of close the gap with the information gap that we have out there with the multilingual communities. There's a lot of radio listeners in both Hispanic, Mandarin, and Vietnamese language. We have ads running on radio stations, 30-second ads, 60-second ads. They all list the key information. And these ads have also led us to 10-minute interview recordings that stations pre-recorded with the help of our native speaking registered nurses from local stroke centers. We have a number of printing materials that we have available for anyone that needs a poster or a flyer in multiple languages. And as Chuck mentioned, the app is really a really important part of our outreach because now in 4 languages, it helps teach the stroke signs and symptoms. It helps find a nearest stroke center, alerts and emergency contacts in a case of an emergency, whether it's stroke or any other emergency. You can list up to 6 emergency contacts in the app. It also shows your geolocation if you dial 911 via the app, which is another feature that is very important for actually identifying where the stroke victim is calling from. We have multiple ways that we can promote this app in digital format, and we encouraged to share this with our community partners just to spread the word. We actually have so the app is nationwide, and we really have hospitals all over nation contacting me, asking to utilize the features of the app, and we're really happy to share all this information. Just to touch on the ambassadors, as Chuck mentioned, we enlisted community members and influencers within each of the targeted communities to kind of gain insights and and find better ways to reach deeper into these diverse neighborhoods and utilize their channels to be more effective in spreading this life-saving messaging. So our list of ambassadors is very diverse. They're all very effectively helped us record video messages, which hopefully this one will play for us, in multiple languages. And we host these on our landing pages, language-specific landing pages in now 6 languages. For example, this one here is Fernando Zazueta. Sorry, it might be a little loud. It is in Spanish, but just for
Hola amigos,
illustration.
les habla Fernando Zazueta con un anuncio muy importante que les puede salvar.
So I won't bore you with the entire message in case you don't speak Spanish, but just to show you, we incorporate stroke signs and symptoms in the video. You know, our audiences are now lazy readers. They really like videos. As soon as we popped up the videos on our landing pages, people spend a lot more time. So this is a very helpful aid, which ends with the request to call 911 when you see stroke symptoms. Here we go. And this is a face you might recognize. Ron Gonzalez also recorded message. This one is actually in English. So if we have time,
Know the signs,
Patty, maybe
save a
you
life.
can.
Hello, I'm Ron Gonzalez, President and CEO of the Hispanic Foundation of Silicon Valley and former mayor of San Jose. In February 2004, I suffered and survived a stroke. So I know personally, a stroke is a real emergency. It's the #1 cause of disability and the #5 killer in our community. Today, stroke is largely treatable if the stroke victim arrives at a hospital in a short time period. I would like to take this opportunity to make a personal plea to you to take quick action when you see the signs of stroke, to call 911, to get to a hospital or clinic immediately. The bottom line is that fast action is really required. Know the signs, save a life. Visit www.strokeinfo.org to learn more about stroke symptoms.
Know the signs and save a life is our messaging that is consistent through all of our advertising. Well, it's really public outreach. And we really would like to share these resources with the community partners and just find more avenues to further the messaging and improve our education in the community.
Absolutely amazing work. It's very inspiring to people to see those videos. Like you said, the Raleigh showed a wonderful video a couple months ago. I don't know how easy it would be for you to tee that up, but it might be nice with this group that, no, not easy at the moment. She's at the hospital. I have to say I have more questions than I have answers. Nirali, you go ahead and facilitate this. I see Chairman Baumer has his hand up.
Yes, and I'm going to be mindful of the time, so maybe just a couple questions and we can, have each other's contact info, and hopefully, Ilana, you guys are doing your outreach in different communities. Use some of these videos. As Noemi said, they're available for everyone. Bill, go ahead.
So Naomi, thank you very much. You may remember I ordered one MSU unit for the first talk. For this talk, I'd like to order one of you for each county in California. So let me know if you would be available, if we could actually spread this to the other counties in California, because I think that these public announcements and your ability to get into radio and to the media, which is most important to each of these populations, is imperative if we're going to get this type of information spread across the state of California.
Absolutely. This is definitely something we can share. Every community is a little different, but this media mix, if you understand the Hispanic community, you know where to go. If you understand the Mandarin speaking community, then you will understand that they are really good with digital information, and we track these results. As I showed you our results, if something's not performing, you pivot and you do more radio. So yes, definitely. We're happy to share information as well. Yeah, this works for any county.
And
Thank you.
to Evelyn's question, so do you have all of these on a channel, the videos, and do you have everything on a link that any one of us who are building patient-facing information in our after visit summaries or in any of our programming can just link to?
So the videos
And if so, just drop it in the chat.
Yeah, so the videos are all on our website. And when you go to our website, which I can share right now if I have it keyed up, you can choose a language and the language will show you stroke signs and symptoms, after which the video that relates to that language will play. I can do this real quick, maybe.
While she's loading that up, does anyone else have a question for the entire panel of our awesome speakers today?
I have a question, and that is, we're very much into prevention, all of us on this line here. And I'm wondering, I just had a little bit of chat with Ram. I won't reveal what you said, but I'm wondering what sort of screening can be done in advance to prevent the event from happening in the first place. Is it that you need to have annual exams? You need to have, talk to us about how we need to change our preventive strategies other than telling people to control their blood pressure, which of course everyone already hears all the time. They don't understand the implications of it. And Ram, maybe you could just express what you learned from the patient perspective.
Sure. Well, as I mentioned earlier, I barely went to a doctor prior to 6 months prior to my stroke. So 6 months prior, actually, at my wife's insistence for years, I went for a colonoscopy because I was, past 50. People say you got to get your colonoscopy. My wife had been at me for not getting it done for several years. I finally, consented and said, okay, go get colonoscopy done. And the doctor basically says, she saw my ECG and said, your ECG looks unusual. You need to go see your PCP. So I scheduled an appointment with my PCP 2 months later, and he looks at it and says, your ECG looks unusual. You should see a cardiologist. By the time I get my appointment, it's like, 3 months after my colonoscopy, and he looks at it and says, yes, it is unusual. Looks like you have something called hypertrophic cardiomyopathy, HCM. And of course, I did not quite get the gist of it. And I had to, get a second opinion, so to say. And he asked me to wear a Zio patch. I did, and it showed a couple of VT incidences, ventricular tachycardia incidences of 190 plus beats per minute. Of course, luckily for me, they're only for 6 seconds or so. So it was not sustained, and I'm still alive. He put that on it, and he said, I didn't quite believe him because I thought I was so healthy. I never had a reason to see a doctor really. And so I said, let's do it again. It must be an error in the device, how it is, taped onto my chest and whatever. So we did it a second time. Similar results, another 2 VT incidences. And then he said, the doctor said, you definitely have HCM and you have to have an ICD inserted. And I scheduled an ICD to be inserted on May 26th of 2019. and May 13th, I had my stroke. So to cut the long story short, it was ultimately determined to be cryptogenic because they really couldn't find anything, any remnants of where the stroke originated. So it was termed as cryptogenic, and till today we really don't know. Only speculation by my HCM specialist that I'm seeing at Stanford is very likely the clot got it built up at the apex of my left ventricle, where it's really narrow because my walls have become very thick. My heart walls have become very thick because of HCM. And because very narrow space, the blood wasn't flowing freely. And that may be the cause for the clot to form. So it's just a speculation. We really don't have any data on it since it's all, gone.
I think Chairman Balmer might want to say something about that. He just gave a program on that with Cleveland Clinic.
No, that's a fascinating story, and it always means we have to do more digging when we first see a symptom or a sign in an individual for that situation. And yes, that we do have new treatments for hypertrophic cardiomyopathy if it is obstructive, and they probably apply to non-obstructive as well. So all my recommendations would be stay with your cardiologist because, it's the good news is for the symptoms and signs and diseases that you have been diagnosed with, we do have therapies, and those therapies significantly reduce symptoms and the chance of events in that case. So very important, but certainly I don't want to drag out all of the therapies that are available right now, but stay tuned with your cardiologist because I think they have a lot to offer. And you have a lot to look forward to.
Yes, I got into this, looking at my health a lot more closely since I've had the stroke. So I am actually trying to develop some software myself to help the process. So, and I don't want to bore everybody here what I do now, but I'm basically doing that full time. I quit my job and I've started to build some software to help the process as I see it from my perspective. And of course, I'll have to bring in the experts like you folks here at some point to, get me focused more closely.
In one of the aspects, Hattie mentioned prevention. In this case, perhaps getting genetic information would be helpful for any relatives because getting a head start on this is much better than waiting for the first symptoms. And Right Care does try to focus on prevention because that's perhaps the best way of preventing subsequent injury and damage.
Yes, I went through genetic counseling, went through the, all the testing, and I passed that information to rest of my family. They all got their genetic testing. Unfortunately, I have one of those genes that, is not of the 6 known gene types or whatever. Mine is not one of those, and therefore, but anyway, but
thank you so much, and everyone who's shared their stories. I think these stories today have just showed us how inspirational being a stroke survivor and being a part of the process really can be. From Chuck's story and your story, Ram, and all of us as providers getting inspired. And so I see the time is approaching 6:15, so we do have to end the meeting. But I just want to thank all of our speakers. I'm getting ideas, from Hattie's question. Okay, like how do we get people to see their primary care doctors? It's great that office, jobs have doctors on site. How do we make it easier? There's so much we can discuss. And so I hope people will continue to innovate. Ram, maybe you'll be giving a talk and when your product is ready, and just continue to ask all of you to think about how we can advance our goals forward to stop stroke, stop heart disease, and keep our community healthy. Hattie, maybe you can announce the next meeting, and thanks to everyone for joining us today. This is really amazing.
It's always hard to stop the conversation. Thank you, Nirali, for reminding us of the time. I always lose track of time. Ram and Lene, others that we've not met before, we welcome you to come back and join us. I mean, we're having another program on stroke on Monday, November 14th, 12 to 2, and we're going to be talking about the importance of sleep. Sleep is a much greater driver of cardiovascular events than we recognize. I'm glad that the Heart and Stroke Association has recently added sleep as an 8th critical indicator of your health. I have to say, I don't work for Apple. My Apple Watch is 5 years old, but it is a really great heart monitor. And one of our recent stroke presentations, Jeff Saver from UCLA, said that it's a major breakthrough that there is fall detection in this device. And so I would just urge all stroke survivors and all people who are concerned about having heart attacks and strokes to consider some sort of fall detection device that could send help if you're not able to speak. So unfortunately, it is the case often with a stroke that you wouldn't be lucky enough to be able to walk up the stairs and tell your boss you're not feeling well. So let's engage the technology. I think there's so much more out there that we can do to prevent these events. And bless all of you innovators for bringing these things together. Thank you, Nirali, for